Hello, my name is Kelly Tebow, and I'm with the New Jersey Center for Tourette Syndrome and Associated Disorders. I will be your organizer for this evening and would like to welcome you to our webinar on PTSD, Unpacking the Myths About Trauma and Exploring Solutions. Thank you all for joining us. Before I have my colleague introduce the speaker for tonight, I'm going to cover some housekeeping items with you. All participants are muted. If you have a question, please type it in the bottom of your question box and click send. You may send questions during the webinar. However, we will have Dr. Infantolino answer the questions at the end of his presentation. We will get to as many queries as time allows. In addition, tonight's presenter is available to take your questions on the Wednesday webinar blog, which is accessed from our homepage under the heading Programs. This blog will be monitored for the next 7 days. Feel free to look and post questions as often as you like. Answers will be archived for future reference. If you missed part of the presentation or would just like to watch it again, an archived version will be posted to the website shortly. We value your input, and in order to expand the webinar experience in the future, we need everyone to fill out the survey as you exit the webinar. NJ Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Pat Phillips, the Education Outreach Coordinator of NJCTS. Pat?
Thank you, Kelly. Good evening, everyone, and welcome to tonight's webinar. Our presenter for this evening is Dr. Zachary Infantolino. Dr. Infantolino received his doctorate from the University of Delaware. He trained at the Center for the Treatment and Study of Anxiety at UPenn and completed an internship at the Rutgers University Counseling Center with a specialization in the treatment of post-traumatic stress disorders, or PTSD. Dr. Infantolino worked as a postdoctoral fellow at Stony Brook University, during which he examined neural markers for predicting the onset of psychological disorders and the psychometric properties of neural measures. While at Stony Brook University, Dr. Infantolino was a study therapist for an NIMH-funded study examining neural changes in children and parents associated with the completion of parent-child interaction therapy. Dr. Infantolino is currently a staff psychologist at Stress and Anxiety Services of New Jersey, where he specializes in the use of cognitive behavioral therapy to treat anxiety disorders, obsessive-compulsive disorder, and post-traumatic stress disorder in children, adolescents, and adults. He is a certified cognitive processing therapy provider and has received training in prolonged exposure and trauma-focused cognitive behavioral therapy for PTSD. Dr. Infantolino, we are truly pleased to have you present for us on PTSD tonight. And now, without further introduction, I'm going to turn tonight's presentation over to you.
Okay, thank you very much, Kelly, and thank you very much, Pat, for that wonderful introduction. I'd just like to welcome everyone today to the webinar and taking time out of your day to attend. I'd also like to thank the sorry, I'm just trying to get things ready on my end. The New Jersey Center for Tourette Syndrome and Associated Disorders for providing me with an opportunity to present today. As you heard, I'll be talking about PTSD. Just to give you, I'm sorry?
Did you get the button that said?
Oh, is it not sharing? I am sorry. Okay, on my end, it looks like it's sharing my slides. Is that not true?
No.
Screen 2. Is it now?
No. Okay, let me take back controls and I will then pass them back to you.
Okay.
It's not allowing me. Okay, this is new. They came up on your screen?
No, I
Okay.
don't have the controls. They did before.
Okay. Yeah, see, now everybody else says they're able to see them over the screen. I haven't taken over the screen yet.
Okay.
So give me one moment and I will fix this issue.
Okay.
Good evening, folks. We're going to get onto the presentation just momentarily as soon as we figure out the technical difficulties that we're having. Just bear with us one moment. Dr. Infantolino, are you still here with us?
I am, yep.
Perhaps you might just want to start to just talk a little bit about your background and maybe some of the things that they're going to be seeing in the presentation this evening. Just kind of a quick overview before we get into it.
Sure, absolutely. So I can talk a little bit about my background. Pat mentioned a lot of it, but I can really highlight the PTSD portion. So while I was a graduate student at the University of Delaware, I was an extern at the Center for the Treatment and Study of Anxiety at the University of Pennsylvania with Dr. Foa. And so if people are aware of treatment of PTSD, Dr. Foa is one of the really one of the main figures as far as one of the main gold standard treatments for PTSD, and that would be prolonged exposure. So I received a lot of great training there, and part of my time there, I was also there was a research component. They were doing studies, and so I was looking at fidelity, so watching a bunch of sessions and coding how faithfully the therapists were conducting the treatment, which was really a great experience for me to get a lot of experience seeing other people administer that treatment. So one of the interesting things about training is that we actually don't have a lot of opportunities to see other providers doing treatment. And so that was really a great experience for that. After that, I went to the Maryland VA system at just north of Baltimore at the Perry Point VA, and continued to engage in prolonged exposure for PTSD, so working with veterans there. And then moving on to internship that was at, again, Rutgers University, the counseling center, and I worked with Dr. Charity Trong, and she had worked on a number of studies in the VA through Strong Star, and she had a background in cognitive processing therapy, and so that's what I focused on when I was at Rutgers.
Excellent.
Okay, so it looks like you can see my screen now, and let me just put these slides up.
Excellent.
Can people see that?
Yes.
Okay. Yeah, that is, I think, all the highlights of my career so far. But I did recently received certification in cognitive processing therapy and have a good amount of experience treating PTSD, which has been extremely rewarding for me. Just to jump back then to the presentation, so just to provide everyone with a roadmap of where we're going to be going today. One is thinking about what experiences can lead to PTSD, and then thinking about what does PTSD look like. So going through the symptoms, how can people present with PTSD? What are the different types of presentations? What's the potential overlap with other disorders, and as far as the presentation? And then thinking about what can be done. So when we recognize that someone has PTSD, or we know that someone has PTSD, what do you do in that situation? And then opening it up for some questions. So let me just start out by talking about some common myths that you often hear. One is that only soldiers develop PTSD, right? So it's only veterans who can have PTSD. You have to have combat experience. If you don't have any exposure to combat, you can't have PTSD. And this is one that's still fairly prevalent. And when I talk about some cases, I will talk a little bit about some individuals that I've worked with that have fell victim to this myth. And it can lead to a delay in treatment because people may not think that they have PTSD, and they may think it's something else, or they may just not seek treatment because they don't realize that that they can have PTSD, and also that PTSD is treatable. Another myth is that everyone who experiences a trauma will develop PTSD. So if you've gone through a horrific experience in your life, you will definitely develop PTSD. So I'll certainly be talking about that. There's also this myth that people with PTSD are weak. It's just something that you have to get over. I've been through a trauma. I'm fine. Why aren't you? There's plenty of other soldiers that have gone through traumatic events, or other individuals that have gone through traumatic events, and it's just that someone with PTSD is weak. And again, I will address that. And then the final is that PTSD cannot be treated. This is unfortunately one that's still out there. And people, they believe that, well, I have PTSD, it's a lifelong disorder, there's nothing I can do about it, there's no help for me, I'm just this way. And unfortunately, you see people who have had PTSD for a long time. When I was at the VA, I saw individuals that had PTSD for 30 or 40 years. And it's just really tough to see that, because we know that there are good treatments. Let me start out with a little bit of history. So very early on, in literary accounts, we can see the first accounts of what we now consider PTSD. So in Homer's The Iliad, in Shakespeare's Henry IV, in Charles Dickens' A Tale of Two Cities, they describe traumatic events and the symptoms that followed, right? So this is something that people have been noticing for a long time now. Initially, it was thought that physical injury led to the symptoms. And so you had things like Joseph Leopold wrote about nostalgia amongst soldiers. And what they would talk about as far as those that experience traumatic events is that they experience symptoms of sadness, sleep problems, anxiety. You also people talk about soldier's heart or irritable heart. And this was characterized by rapid pulse, anxiety, trouble breathing, so these panic-like symptoms. And then you also had something called railway spine. So as there was an increase in the frequency of trains and the use of trains, there was also an increase in train accidents and train injuries. And so many people after these injuries would experience similar PTSD-like symptoms. And then as we move on, we see the first attempts to start to treat PTSD as a medical problem, and that actually is earlier in the Civil War and the Franco-Prussian War. And over time, the PTSD has gone by a number of different names. So I mentioned some of the previous ones, but then in World War I, you had shell shock. And so it's originally thought that this was related to being near big explosions. And then they started to notice that people who weren't near big explosions exhibited similar symptoms. And so then they changed that to war neuroses. And in the early forms of treatment, you would see, people would rest for a few days. The treatments would focus on increasing everyday functioning. These were the very early forms. In World War II, what you would see, they would refer to it as combat stress reaction or battle fatigue. And the way that they would treat it at that time was to focusing on preventing stress and promoting recovery by focusing on the benefits of the military unit and the relationships and the support in those units. And then PTSD, or the early beginnings of what we now call PTSD, was first incorporated into the Diagnostic and Statistical Manual of Mental Disorders, which is what psychologists and psychiatrists use to make diagnoses. So it was in DSM-1, and then it was actually removed for the second version of DSM, but then resurfaced in the third version, due in large part to research involving Vietnam veterans, Holocaust survivors, sexual trauma victims, and others. And so as you can see, over the course of researching PTSD, a lot of it has been related to trauma reactions from military combat. And so I think that is unfortunately why one of those myths does propagate, is that a lot of the research is focused on combat trauma. But the reality is people who have never been exposed to military combat can still experience PTSD. So let's talk a little bit about what can lead to PTSD. There's a number of different events that can lead to it. And so I'm going to be pulling from the Life Events Checklist, which is a tool that we use to assess for traumatic events. And so I'm just going to read off a bunch, but also give you a graphic from a recent study by Kilpatrick and colleagues. And some of the events are natural disasters. So floods, hurricanes, tornadoes, earthquakes, fires or explosions, transportation accidents that can include car accidents, boat accidents, train wrecks, plane crashes, a serious accident at work, home, or during recreational activity, an exposure to toxic substances, so dangerous chemicals, radiation, physical assaults, being attacked, hit, kicked, slapped, beaten up, assault with a weapon, being shot, stabbed, threatened with a knife, gun, or bomb. You can think of terrorist attacks. Sexual assault, rape, attempted rape, made to perform any type of sexual act through force or threat of harm. Captivity, being kidnapped, abducted, held hostage, prisoners of war. Also life-threatening injury or illnesses. Experiencing a sudden violent death, so either homicide or suicide. Sudden accidental deaths. And then we also have combat exposure or exposure to warlike zones in the military and as a civilian. So as you may have noticed, there's actually a number of events that can lead to PTSD, and many of them are not associated with any military service. And also a lot of you might be thinking to yourselves that you or someone close to you has experienced one of these things. And this is likely true because in this study, and this is consistent with a number of other studies, nearly 90% of individuals experience a traumatic event in their lifetime. So the majority of people, the vast majority of people will experience a traumatic event. And we'll talk a little bit more later on as far as what happens and why doesn't everyone develop PTSD. And I just want to highlight combat or war zone exposure that only ends up being just under 8% in the general population as far as what they experience. You can see some of these others that are much higher, thinking of natural disasters, accidents or fires, physical or sexual assault, the death of a close family or friend due to violence, accident, or disaster. Right? And so again, there's a wide variety of types of traumas that can lead to PTSD. And so when we think about this, we want to think about, well, what is kind of a cohesive definition for what actually counts? And so that what the DSM lists is if you're exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. And so that can be either through direct exposure, so these things happen to you. It can be you witnessed it in person. It could also be indirectly. So you learn that a close relative or close friend was exposed to the trauma. Or it could be repeated or extreme indirect exposure to aversive details of the event. And this is often we think about individuals whose professional, this is their job, right? So thinking about individuals who are tasked with maybe child abuse and listening to those details. Or one that has come up in the media fairly recently is individuals that are tasked with taking pictures down from social media, right? So looking through all of these gross or gruesome or grim pictures and thinking about that exposure. And the impact that that can have. Now, the DSM does make a distinction that if the exposure is through electronic media, television, movies, or pictures, it only applies if the exposure is work-related. One that I just want to highlight because I think that it is a type of trauma that is often underappreciated and I saw frequently is sexual violence. And so in the DSM, this is described as forced sexual penetration, alcohol or drug facilitated sexual penetration, abusive sexual contact, non-contact sexual abuse, or sexual trafficking. And again, this is one that I've seen a lot, and I think it's really important to highlight given some of the discussions that are going on in the world right now, and thinking about how these are handled. So one of the ones I do want to highlight is the inability to provide consent because of drug or alcohol use. That is one that came up a lot when I was at Rutgers. And another one that we're starting to see with alarming frequency is coerced into sexual acts. And so we're actually seeing this in middle schoolers that are coercing girls into sending inappropriate pictures of themselves. And so this does qualify, right, as coercion, saying that they are going to say negative things about them to their peers, or tell everyone that they did send the pictures when they didn't, right? So there's all these coercive acts that come up, and I think it's important to recognize the role that these play, because I think sometimes these things can be not taken, I want to choose my words carefully, but they can maybe not be viewed as leading towards PTSD or leading to PTSD, and I think we want to make sure that we are keeping in mind that these do fit the criteria. So just to go back and address, why don't 90% of people have PTSD, right? So not everyone that experiences a traumatic event, we said 90% develop symptoms of PTSD. And so what I want to do is I want to differentiate PTSD from normal reactions after traumatic experiences. And the main difference there is the amount of time that you experience those symptoms. So after a traumatic event, nearly everyone is going to react in a similar way, right? So you have kind of baseline symptoms, and then you have a traumatic event, those symptoms spike. And what typically happens is that those symptoms will decrease over time. For someone with PTSD, though, those symptoms do not decrease, they stay elevated. So let me give you a quick example. Thinking about a car accident. Say that you are driving, you're stopped at an intersection, your light turns green, you start going through the intersection, and then all of a sudden a car comes flying through, runs the red light, T-bones your car, the car's totaled. You mostly find that you're pretty shaken up, you have some bumps and bruises. You get home, you seek medical attention. Then the next time you drive, maybe it's a day later, maybe it's a couple days later, when you get in your car, your heart may start to race. Your palms may get sweaty. You may start to experience thoughts about the accident. And then as you're driving, you may be overly cautious, right? You may be driving very slowly. You may be looking around constantly. When the light turns green, you might wait for 30 seconds, which will earn you a honk in New Jersey. And I lived on Long Island, and they're bad there too, so I'm not picking on New Jersey. And you may be thinking to yourself, what a death trap driving is, right? Why this is crazy. I'm definitely going to get in an accident today. And so that would be the typical spike that we see in post-traumatic symptoms that the majority of people experience. However, as time goes by and you start to drive more without being involved in an accident, those symptoms will start to decrease. That's that natural decrease. Unfortunately, for someone who develops PTSD, those symptoms do not decrease on their own. They stay elevated. And this isn't a sign of mental weakness or someone that's just not getting over it. There's something that has gotten in the way of the natural healing process that needs to be helped along. And the way that I like to describe it to clients is that if you broke your arm, you could just kind of tough that out. If it's not too bad, if it's not broken through the skin, it'll probably heal okay. It's not exactly how you would want it, but you could tough that out. But most people would probably go to the emergency room, they would see an orthopedist, they would set the bone, they would put a cast on, and they would send you on your way. Now, it's not that the orthopedist is healing your bone, right? They didn't do anything magical for that healing process. Your body's doing the healing, but they're helping it along. And that's the same way that we think about PTSD. We're not doing anything magical, but we are helping that natural process along. And this is just the 1 month criteria where you actually can't diagnose PTSD unless they've had those symptoms for at least a month. And so that does highlight that there is this natural response after a traumatic event. Let's talk a little bit about PTSD symptoms. You have 4 main symptom clusters. First, you have the intrusive symptoms. So these can take the form of unwanted, upsetting memories. Maybe you're sitting at work, or you are driving to work, or you are spending time with your kids, and all of a sudden thoughts about the trauma come up. You're not trying to think about it, you are not prompted by anything, but they just come in. We call those intrusive thoughts. They can also take the form of nightmares. You wake up in the middle of the night, you just had a dream that was identical to the event or very similar as far as its theme to the event. They can also take the form of flashbacks. Now, flashbacks have been sensationalized a little bit in the media and are actually relatively rare, but what they are is when an individual has difficulty differentiating, is the event happening to them again, or are they in the present moment? And so it really is that not knowing what's actually real. Your kind of classic example would be maybe a combat veteran who has PTSD. They hear fireworks going off on 4th of July and they jump under the table because they don't recognize that they're in present day and they're in a safe place, but they think that they are back in the combat zone and they need to take cover. Again, relatively rare. Mostly what we see, a lot of people will think that the intrusive thoughts are flashbacks, but it is helpful to make that differentiation. And then rounding out the intrusive symptoms, you also have emotional distress after trauma reminders and physical reactivity. So emotional distress, becoming upset, typically crying is kind of an indicator, but can also be experiencing anger. And then that physical reactivity is what you think of as the classic fight or flight response. So typically increased heart rate, changes in your breathing, maybe weakness, maybe numbness on your extremities, a little bit of shaking maybe. Sometimes you can feel dizzy, GI symptoms, right? That whole fight or flight cluster. We also have avoidance. And so this is avoiding trauma-related thoughts or feelings. So people may do a lot of things to try to avoid it, right? This was this negative experience you had. You just don't want to think about it. It's upsetting. I just don't want to deal with it. So I'm going to do what I can to avoid. And then also avoiding external reminders. So that can be avoiding where you're going. And I want to make a differentiation of avoiding unsafe situations and avoiding objectively safe situations. So it's a symptom if they're avoiding objectively safe situations. So say an individual was held up at gunpoint in a bad neighborhood at night, and they then will not go out at night at all. Maybe they live in an objectively safe neighborhood, their neighbors go for walks at night, walk the dog, they go for a jog, whatever it is, and this individual will just not go out because it's too much of a reminder. And to highlight the avoidance, there can be various things that people will do to avoid. So there's kind of that outright just not going and doing things. There can be people may turn into workaholics. They may put a lot on their plate so they don't have any time to think about the trauma, to try to push everything away. And then you also start to see drug and alcohol abuse. That's a way to avoid, right, to alter your mental state. And then we have negative alterations in cognitions and mood. So what encompasses that is you have your inability to recall key aspects of the trauma. So that's not related to substance abuse, but you've kind of failed to encode certain aspects. Overly negative thoughts and assumptions about oneself or the world. So if you think about my example with the car, this idea that, well, driving's just a death trap. Everyone's a terrible driver. I'm definitely going to get into an accident. Everyone's just not paying attention and they're going to run into me. You can also have exaggerated blame of self or others for causing the trauma. And often the way that we think about this is if you, especially for the self-blame, if you're blaming yourself, it provides you with a level of control, right? If it's something that I did, I can then make a different choice in the future. But often there is inappropriate self-blame. And the kind of classic example is, for a sexual assault victim, well, I wore the dress last night. A dress has nothing to do with an individual sexually assaulting or raping you, but by blaming yourself, it can be an attempt to take back that control. So you see that exaggerated blame of self. And then as far as others, again, that would be inappropriate. And so you can see this in children who are abused, and maybe one parent was the abuser, the other parent did not know, and they may blame the parent that did not know. So it's kind of that inappropriate blame. It's not the parent that didn't know that abused them. There's a perpetrator in that situation. You also have negative affect, so your depressed mood, decrease in interest in activities that they typically used to enjoy, feeling isolated, feeling like they can't connect with other individuals, and then also difficulty experiencing positive affect. So they may have trouble experiencing joy, happiness, or love. Just a hard time connecting with those positive emotions, and much more of a bias towards those negative emotions. And then finally, we have alterations in arousal and reactivity. So that includes irritability or aggression. People with PTSD can be irritable, can get angered easily. You can see risky or destructive behavior. Hypervigilance, so constantly being on guard, right? In the example I gave with the car, they're constantly looking around for someone running the red light or someone about to hit you. You may experience a heightened startle reaction. So if you hear a door slam, you jump a mile high. Difficulty concentrating. Can be difficult to focus on work, can be difficult to focus on conversations, and also difficulty sleeping. That can be falling asleep, staying asleep, waking up early and not being able to fall back asleep. And so you have these 4 domains of PTSD symptoms. Now, one thing that can be difficult is that PTSD can look like other disorders. You do start to see misdiagnoses at times. So if you think about some of those mood symptoms, it can start to look like depression. You have sadness, loss of interest in activities, feeling isolated, difficulty experiencing positive emotion, negative thoughts about oneself and the world, right? That can start to look like depression, can be misdiagnosed as depression. A number of the reactivity and avoidance symptoms can start to look like standard anxiety, right? That avoidance, your classic fight or flight symptoms of anxiety. And so we want to really be careful to make a proper diagnosis here. And the avoidance can also take the form, as I said, of drug or alcohol abuse, and can be mislabeled. They can have a drug or alcohol problem, but we also want to know if PTSD is at play there. And so just to kind of touch base on a couple of clinical examples that I'll highlight, and I'll come back to some of these examples with some of the difficulties. And these are just combinations of clients I've seen, so no one individual that I'm speaking about here, but just a few individuals, or I'll go through a few examples. One is a girl in her early adolescence, and had experienced childhood sexual trauma, sexual abuse by a parent. And coming to treatment, there was significant avoidance, not wanting to say that it was a problem, depressed mood, eating issues. Her sister had also been abused, and there was this invalidating of the sister's experience. It was fine, nothing was problematic. And so this not willing to, or the inability to say that it was sexual abuse and say that it was a problem, this was difficult at first, and you can also see where that can be difficult when I highlight of what people can do. And part of it was this impact of what it would mean for some individuals. What would it mean to admit that this happened, right? So especially for childhood abuse, that's a pretty difficult thing to wrap your head around. If you have this individual who is supposed to love you and supposed to protect you and take care of you, is then doing this thing that is actually terrible for you. And it can be really difficult to have that shift. And what does that mean for the family? as difficult and as bad as these situations can be, it can also be difficult to break up a family in the child's eyes, and so that can be difficult. And so, sometimes children may not be straightforward with what's happening. Right? There can be a lot of denial, which is why it can be helpful to notice some of those other symptoms that we talked about. One that I'll highlight, one category that I'll highlight is related to sexual violence. And so I talked about this a little bit at Rutgers, and what we would see was oftentimes individuals that had too much to drink. They were not able to give consent because they had too much to drink, and then unfortunately they receive a number of messages of blame. And so what happens is they then don't come forward for PTSD, right? They don't think that they have PTSD. Well, it was just, I shouldn't have slept with this person, or I cheated on my boyfriend, when the reality is they were sexually assaulted. And so we also need to be on the lookout of, if someone is presenting to us, someone is having these concerns, thinking about PTSD. And I think one of the main takeaways is going to be that, what I really want people to be able to recognize is what are the symptoms of PTSD, and then also keeping in mind that PTSD is a possibility. And then the last one I'll talk about, type of trauma, is individuals that have that myth of PTSD is for combat veterans. So I've seen a number of individuals who, and maybe had a trauma earlier in their life, maybe in their 20s, they're in their 40s, 50s, 60s, and they've never viewed it as PTSD. They've had a lot of the symptoms, and they've just never viewed it as PTSD because that is something that only veterans can have. And so it can take a little while for them to recognize. I had one individual who, it was only when he took a job with the government and worked with veterans, and they started to notice his symptoms and said, hey, I think you have PTSD. And that was the first time where he really put that together. So again, I think it's just helpful to share some of those examples, and I'll touch base on some of those issues as we go throughout. And I do want to touch base on the differences across the lifespan, because we do start to see different presentations of symptoms. So for children who are under 6, you can start to see, they'll show signs of fear. They will cling to their parents. They will cry or scream, right? You can see that change in mood. They may move about aimlessly, and they may return to behaviors that are common when they're younger. So you can see things like thumb sucking, bedwetting, being afraid of the dark, all of these things that they've moved past that stage, but then they start to regress. For children who are 6 to 11, you can see they may start to isolate themselves, be less social, maybe quiet around friends, family, or teachers. Maybe they were typically relatively engaged, but then they pull back. Trouble with bedtime, that can be refusing to go to bed, having nightmares, trouble sleeping. Oftentimes with childhood, especially sexual abuse, it can happen around bedtime or in the bed. And so if we then think about those trauma reminders, right, the bed is going to be, or bedtime is going to be, a major trauma reminder. And so you may start to see a flare up in symptoms at that time. And I'll talk a little bit more about how that kind of works. You may start to see angry outbursts. So one of the things that can happen with children is some of the PTSD symptoms can start to look like oppositional behavior. And so parents may present, well, my kid's just not listening to me. They're having these angry outbursts, they're having temper tantrums, and but we want to be thinking about, well, what is driving that behavior? Because it can be driven by fear. They may also have trouble concentrating. So this could show up either in interactions with the family or also at school. For children who are doing well in school and all of a sudden those grades start to dip, we may be thinking about, well, is there something else that's going on there? And they may also start to complain about physical problems. So there can be this somatization of the PTSD. For adolescents, you can start to see using drugs, alcohol, or tobacco, right? Thinking about those avoidance strategies. Again, other types of avoidance, whether that is not engaging in certain situations, avoiding certain people. You can start to see disruptive, disrespectful, or behaving destructively, right? Again, this can start to look like oppositional behavior. They can also come up with physical complaints. It can be a more acceptable way to discuss their symptoms. And then you may start to experience loss of interest of things that they typically enjoy. So maybe they used to enjoy playing basketball and then they stopped doing that. Maybe they used to enjoy playing video games, they stopped doing that. You can also start to see suicidal thoughts. And I'm going to come back to this, but I just want to highlight that whenever someone is expressing suicidal thoughts, we want to be taking those seriously. At the other end of the lifespan, older adults, you start to see fewer symptoms associated with the hyperarousal, the avoidance, and the negative cognitions and mood. And what you do start to see is negative perceptions about their health, thinking about it can take the form of how long I'm going to live, whether I'm going to get better from some ailment. You see increased primary care utilization, which can also be associated with a negative perception of their health. And then again, you can also see suicidal ideation, which we want to be taking seriously. So just to kind of give a look behind the curtain of what's actually happening, when someone experiences a traumatic event, all of the sensory information, so you have the sounds, smells, touch, sights, tastes, all of that gets, at the time of the event, gets bound together into what we call a fear structure. And so why is that? Well, if we think from an evolutionary perspective, say that a caveman is walking, and apparently cavemen had nice backpacks because you need to carry things when you're a caveman, and they're walking along this trail and they see a tiger. First, their bodies are going to react in a way that increases their chance of survival. So the classic, what we hear is fight or flight. It's important to include another reaction for PTSD because this is something that comes up and can really throw people off, and that is the freeze response. So if you are in a dangerous situation, your body is going to do what it thinks will maximize its survival. So if you think you can run away or fight it off, you are going to take some sort of action and do something. If you don't think that you can run away or fight it off, your best chance may be to freeze and hope that it passes, hope that it doesn't, the tiger doesn't see you. And I really want to, again, highlight that freeze response because that can really be misinterpreted with individuals with PTSD of, why did my body fail me? Why didn't I say no? What happened? Did I actually want this to happen because I didn't move? And it's really important to highlight that freeze response. And if you do make it out of that situation when you're walking with a tiger, you're going to want to remember everything that you can about what you noticed when you saw that tiger so that you can increase your chances that you avoid one in the future. Right? If I notice that, well, okay, there was a patch of trees, there was some dead grass, there was a dirt path, I want to know all of that. And when I'm in a situation that has all of those, or maybe two of those, or maybe even just one of those, I want to know and I want to be on the lookout. And maybe I actually want to avoid those situations because it is better to be safe than to be eaten. And research has shown that cues that indicate danger generalize very easily. So we see in this situation, there's a dirt road. Well, that may generalize to dirt roads, gravel roads, paved roads, any sort of roads. Because again, it's better to be safe than to be eaten. And then what's difficult is that cues that indicate safety, those are very slow to generalize. And so that will come up with treatment and how that's conducted. So if we go back to present day, what happens when someone experiences an innocuous stimulus and that fear structure is activated? So maybe you see a path, you see a nice patch of trees, that's 2 out of 3, that's close enough. We are going to activate our fear structure because I want to be ready for a tiger. I saw a tiger in a situation that was similar to this. I need to be ready. And they have this strong response, increased heart rate, GI symptoms, changes in breathing, your whole fight or flight or freeze response. Now remember, this is the body trying to protect us. It doesn't feel great at the time, and it may be misguided because the individual may be in a objectively safe situation. But again, this is the body trying to protect us. But unfortunately, often we are reacting as if there's danger in an objectively safe situation. So in the case of rape or sexual assault, maybe the individual is wearing a particular type of cologne or body wash. The individual gets a whiff of that throughout their daily life. Maybe they're on the subway, they're on the train, they're walking in the halls, and it activates that fear structure. For a veteran who has combat trauma related to blasts, gunshots, fireworks are incredibly difficult. You have the The sound as well as some of the smell can also activate that response. Again, for individuals that have been abused, touch can be very difficult. It can really set off that response. And so I think it's helpful to recognize that when children or any individuals with PTSD are reacting so strongly to these seemingly innocuous stimuli, this is what's happening. That fear structure is getting activated and they are reacting as if there is a tiger in the room, or as if they're in danger. So if we think about the children who start to look like they are oppositional, I always remind parents that they are reacting as if there's a tiger in the room. You know, if I was sitting in my office talking with a parent and a tiger jumped in, I'm going to do some things that are pretty unprofessional because I don't want to die. And that is how your child is reacting. And so we need to understand that, because we don't want to be blaming the child. The child is reacting as if there's a tiger. We want to be thinking about, okay, what is the best way to overcome this? So we talked about the symptoms. Why do they stay elevated, right? What happens here? Typically, after traumatic event symptoms decrease, individuals with PTSD, they don't. What we think gets in the way are two main things. One of them is avoidance, so avoiding objectively safe situations. If we go back to the car example, if an individual gets into a car accident and then they say, you know what, I'm never driving again. Well, they never get a chance to learn that driving, while there is some inherent danger in driving and some risk of getting into an accident, most people are able to drive and don't get into a serious accident. And so they never receive that, what we call corrective information, and they're just stuck with that post-traumatic thought. And by not engaging in driving again, they never get a chance to challenge that thought. And so you have that avoidance and then also the thoughts. So what are people telling themselves that aren't accurate that keeps them stuck in the PTSD? Well, if you're telling yourself that every time I drive, I'm going to get into an accident, well, of course, why would you ever drive? So those two work in tandem to keep people stuck in PTSD. Unfortunately, the bottom line is we don't know who will develop PTSD and who will not. It's research that people are working on, but we don't know at this point. Okay, so let's talk a little bit about what can be done. The first is going to be looking for warning signs that may indicate that someone is suffering from PTSD. So I've talked about those, the symptoms already, but I'm going to go through and talk about, I know we have different individuals from different backgrounds on the webinar, and so I want to address some of those broad categories. But we want to notice warning signs, right? Because we talked about, well, this could be PTSD, this could be depression, this could be anxiety, this could be drug or alcohol abuse. And we want to be recognizing those and then doing what we can in that situation. Being supportive, so allowing the individual to experience their emotions, listen if that's what they're looking for, making a referral to a clinician. You know, so as I talked about, we really want to be assessing for traumatic events. So any proper intake session should include some questions about traumatic events. You know, there are easy checklists like the life events checklist that I highlighted, but just getting a sense of, are there traumatic events? Now, as I mentioned, given some of these myths, just saying, have you experienced a traumatic event may not be enough for some individuals. You may really have to highlight what is a traumatic event. It may be easier to just list, have you experienced any of these things? And getting a sense of, have those things had a lasting impact on you? And then the last thing is treatment, evidence-based treatment. So fortunately, there are a number of empirically supported treatments for PTSD, and people who receive good treatment for PTSD do get better. They get better relatively quickly. So I'll talk a little bit more about the treatment, but it is relatively quickly. And you often don't see any sort of relapse. So the follow-up data looks very good for these individuals. And so, you know, for individuals that do have PTSD, we really want to focus on getting treatment, because there's no need for them to be suffering for years or decades when there are good treatments out there. All right, so thinking about what can parents, spouses, or friends do. First, they may be the ones that are most likely to know whether a child, friend, parent has suffered any sort of traumatic event. right? So if we think about all the different events that I mentioned, there's a lot of different events there, and people often have a good idea of, well, what's going on in their life. As I mentioned, you have the avoidance. So getting an idea, okay, well, this person, my friend used to do these things, but now they seem to avoid that, or they seem to be taking this different route for no reason, or well, my child used to enjoy going over to this person's house, but now they cry when we mention it, and they don't want to go at all. Being aware of those avoidance patterns. Noticing changes in mood. If you notice broad changes in mood, thinking about, okay, what's going on there? Why do they have those changes in their mood? Any sort of thoughts of harming themselves, again, we want to be taking those seriously, reaching out to appropriate resources if individuals are serious about harming themselves, right? So 911, the emergency room, psychiatric emergency rooms. If individuals are easily startled, you notice that all of a sudden somebody, when you tap them on the shoulder, they jump. They never used to do that. All of a sudden they're doing that. Hypervigilance, that's one that people can often notice of, the individual that has to sit with their back to the wall at a restaurant, facing all of the exits and the entrances, being able to keep an eye on everything. Or sitting all the way in the back corner of the movie theater so they can look at everything. The individual that has to scan the perimeter of their home before they go to bed at night. The individual that has night vision goggles in case they hear a twig snap outside. And I also want to highlight the acting out, because again, that is one that can start to look like oppositional behavior, but it could be a symptom of PTSD. First, I do think it's important to remember to not over pathologize, right? To remember after a traumatic event, everyone experiences symptoms. So if someone just went through a traumatic event and they're exhibiting those symptoms, that's to be expected, right? I gave that example of a car. Another silly example that I often give is if I see a large bug in my apartment, I don't like bugs. I don't like them in my living space. If they want to spend their time outside, that's fine, but don't encroach upon my living space. If I see a large bug and I kill it, the next time I go into that room, I kind of take a quick scan. And then maybe the next time I go in, I take a briefer scan, right? But I have that hypervigilance at first, and it goes away pretty quickly because it's a bug. But we don't want to over pathologize. These reactions are natural, and their goal is to keep the individual safe. So what we want to be thinking about is, okay, have these symptoms stayed heightened for a while? Again, being supportive, listening, encouraging them to engage in what they're scared of when they're ready, providing reassurance, reassuring them that the event is not their fault, that you'll do your best to take care of them. Again, this is some of this is more geared towards parents. It's okay for them to feel upset, right? So there's nothing wrong with being upset. Negative emotions are not problematic to experience. It's a natural occurrence in life, and so we don't want them to feel like they have to avoid those emotions. If we think back to the symptoms of PTSD, one of them is avoidance of those emotional experiences following reminders. And then thinking about therapy. You are their parent, spouse, or friend, not their therapist. You can be supportive, you can do what you can, but ultimately you want to be trying to connect that individual with a therapist that engages in empirically supported treatment. And I'll talk a little bit more about what that looks like when I talk about treatment in a couple of slides. All right, as far as teachers, now, just to warn you, there's going to be a fair amount of overlap, but it's being aware of traumatic events. Teachers may be aware of when there are major events that are going on. Changes in the classroom, what are they noticing? Do they see sudden drops in grades, changes in socializing? Maybe little Johnny used to be a social butterfly, and then he's really pulled back, or he used to interact with certain individuals, and now all of a sudden he doesn't. And again, I recognize that some of these are natural behaviors. I talk to my nieces, and at the holidays, they are talking to me about one friend, and then 2 months later, I see them, and I don't hear about that friend at all, they're on to another friend, right? So there are some natural changes, but thinking about the whole picture of, are you seeing a number of these different symptoms together? Seeing broad changes in mood. If the child is down all of a sudden, they used to be more of an upbeat individual, and then you notice that decrease in mood. Seeing an increase in disruptive behavior, so that's something that can come up, right? So this, if the child starts acting out in class, it may not be that they are, again, that oppositional component, it may be that there's something else going on. Noticing if students are easily startled. Notice if they're experiencing strong emotions. Do you see them crying unexpectedly? Do you see them lashing out in anger? And again, thoughts of harming themselves, we want to be taking that seriously. Anything about wanting to hurt or harm themselves, or talking about wishing they were dead, again, taking these seriously and taking the appropriate actions. Again, don't over pathologize. These symptoms do happen after traumatic events. Being supportive, providing reassurance, it's okay for them to feel upset. Encouraging the child to speak with a school counselor if they're upset. Now, it's okay to talk about these things. And then also bringing up your concerns with a parent. They may be noticing similar symptoms at home. For professionals, it's very important to remember that PTSD is treatable. And engaging in empirically supported treatments. So these are the treatments that are strongly recommended by the American Psychological Association. You have cognitive processing therapy, prolonged exposure, cognitive behavioral therapy, cognitive therapy, and then I put on trauma-focused cognitive behavioral therapy. That falls under cognitive behavioral therapy. I just highlight that because that is one of the gold standard treatments for PTSD in children and adolescents, and so I just want to make sure that people are aware of some of these terms so that they have an idea. Just a little bit about treatment. So the treatment's going to have some slightly different targets, but all of them aim to reduce symptoms. Some are going to focus on the avoidance more specifically. Some are going to focus on those negative thoughts and moods, but the goal is going to be reducing those intrusive symptoms and that arousal and reactivity. Fortunately, it is possible and relatively easy to receive training in empirically supported treatment. So I have some links there for cognitive processing therapy is the first one, prolonged exposure is the second, trauma-focused CBT is the third. Now, I know with training, sometimes they can get pricey, especially when you get into consultation, but there are also relatively low-cost options. The Medical University of South Carolina does have some great online options, although I do think that it is helpful to have some sort of consultation or to at least be consulting with individuals in your practice or your setting that do have experience with this, because it can be a little tricky. And I think it's also helpful to have other people that are doing this at the same time, because it can really wear you out. I know when I was on internship and you would see 5 trauma cases in a row, it could get challenging at times. And I also want to highlight that there's a lot of measures out there, a lot of resources out there. A lot of research has gone into this, and a lot of the research is through the VA, through the government. And what's great about that is all of those resources are then free. And so you have the life events checklist, which is, I mentioned, a checklist of events that could lead to PTSD. The PCL-5 is a measure for assessing symptoms. The CAPS-5 is a structured interview to assess for PTSD. These are just some resources for everyone, not just providers. Again, the VA has a lot of great material, for professionals as well as individuals with PTSD and individuals that have loved ones who have PTSD. The NIMH website has a lot of great information about PTSD, so that's the National Institute of Mental Health. And then I also highlighted kidshealth.org is actually a website that is through Nemours. They have a large hospital in Delaware and then other locations, but they have a lot of good PTSD resources there as far as understanding. So if people are interested in understanding more about it, there's those resources. And then obviously there'll be the questions and the blog, and then I'll also provide my contact information if people have other direct questions. So just as far as takeaways and what I hope that people took away from this is that PTSD can result from more than just combat trauma, right? There's a lot of traumatic experiences. Most people have experienced a traumatic event, but there's a lot of traumas other than combat that can lead to PTSD. Many people that experience a traumatic event do not develop PTSD, right? So I said 90%, nearly 90% of individuals will experience a traumatic event. The prevalence rates of PTSD is somewhere around 9%, right? So there's a lot of people that experience a traumatic event that do not develop it. PTSD is not a sign of weakness. It's not someone just not getting over it. It's not that they're not mentally strong enough. It is something has gotten in the way of a natural process. Think of it like a bone. You would have that bone set and your body would take care of that natural process. Treatment for PTSD is like setting that bone. We're helping you go through that natural process. And I think it's also really important to remember that there are excellent treatments for PTSD. All right, so I just want to thank everyone again for taking the time out of your busy lives to join me for this webinar this evening. I believe that we have about 10 minutes for questions. So while people are typing their questions, I'm just going to give a couple of quick plugs. One is just where I work, Stress and Anxiety Services of New Jersey. We do utilize empirically supported treatments for PTSD, OCD, social anxiety, panic disorder, phobias, and body-focused repetitive behaviors. There is my contact information. That is my work email and my work phone number. We do have 2 locations, one in East Brunswick, one in Florham Park. And then just the other quick plug that I want to give is for OCD New Jersey, which is the local affiliate for the International OCD Foundation. We're going to be having a conference this coming Sunday. I believe it's 10 to 3. Dr. Alec Pollard is going to be speaking on academic and occupational perfectionism. He's a really great speaker on OCD, and I don't say that for everyone. I saw him speak recently. I've seen a number of people speak about OCD, and I was not that excited to see him, but he really was great to hear. And then we also have a Living with OCD panel. So that is individuals that have OCD or have received treatment for OCD, and they're talking about their experiences. Can really be a great experience there. So again, thank you very much. And then I will switch that over to questions.
Oh, thank you. Thank you so much, Dr. Infantolino. That was really a lot of great information. And we also have some really good questions that have come in while you were speaking. So I'm just going to jump right into the questions that were formulated when you were speaking this evening. In terms of you talked a lot about these life events that happen, also symptoms for young people who might be have symptoms of PTSD. And there's an instance here where there's a young person, an elementary school student, who is in an environment at home where they have an alcoholic parent who's often screaming at them and coming home inebriated and screaming at them. What might this young person be experiencing is what they'd like to know. What might they be experiencing? Could they eventually suffer from PTSD?
Yeah, so, I think they're certainly at great risk for it. I think my first thought in that situation is safety. Is this child in a safe situation? Are there opportunities for neglect or for abuse? So again, first thought is thinking about safety and is this child safe? And then as far as PTSD, I think unfortunately the child probably is at risk. Again, I think it is helpful to remember though, a lot of people experience traumatic events. Not everyone develops PTSD. And so I think, just one other piece that may be worth pointing out in this situation is if the child is able to get help, there is some great research. This is with combat veterans, but those that are in active duty, so they are still in the military, they do get better. Ideally, we would like to remove that negative situation, but there can still be gains made.
Okay, thank you for that. I have another question here. Now you talked also about life events that happen, whether someone's in a car accident or sexual assault. But other than life events, if you if let's say you have an experience, the question here is for a seemingly normal business transaction that turns out to be very stressful and results in some significant consequences. And whenever a similar transaction presents itself again, you experience maybe a fight or flight or some kind of avoidance and some of the symptoms you described. Eventually, you avoid even any other type of transactions that relate to the business transaction that you first initiated. Could that be some type of PTSD or form of PTSD, even though it's not a life event as you described?
Yeah, that's a great question. And this is where you get into some of the weeds as far as the actual diagnosis of PTSD and sort of how those hairs were split on how we actually make that diagnosis. And there's a lot of different reasons, and I won't necessarily get into those. But, the way that I like to think about it is as a clinician, we use the diagnostic codes as a way to guide our treatment and as a way to communicate with insurance realistically. And so what we typically think about when treating is treating symptoms. And so, if the symptoms are similar to PTSD, we would treat those similarly. The type of treatments that we do, thinking about cognitive processing therapy, prolonged exposure, or trauma-focused cognitive behavioral therapy, they're broadly cognitive behavioral therapy, just slightly repackaged, and the focus is slightly different, but it's all sort of methods that we would use for any type of anxiety or depression. And so I think in this situation, the symptoms could be very similar. As far as whether or not it would make a formal diagnosis of PTSD, I think that's an open question, but I think it could be treated very similarly.
Okay, great. Thank you for
Mm-hmm.
for that answer. Another question here. Particular incident here where they have a young child in a school environment who is constantly acting like there's a tiger coming after them or following them. How might one handle that? How would you help a child
Yeah, and
in that
so
situation?
I'm just going to assume metaphorically a tiger is coming and they're not experiencing some sort of hallucination. But as far as what can be done, I think being able to try to reassure them that they are safe, maybe getting a sense of what they are concerned about. And I think that's a situation of really, providing them that space, whether that is with the school counselor, touching base with the parents, and are they noticing this at home? Maybe also making recommendations to, it seems like a good indication that the child may be experiencing some sort of anxiety disorder, and that talking to someone could be helpful. But I think as far as what the teacher can do in that moment is really focusing on trying to reassure the child that they're going to be okay, that they are in a safe place. And, we do think about what are accommodations that can be made for children to try to make life a little bit easier. And then over the course of treatment, we would expect those accommodations to decrease as the symptoms decrease, but there's nothing wrong with starting out with accommodations to help them feel safer.
Great. Excellent. Another one question here for you, Dr. Infantolino. What do you think about EMDR for PTSD?
Yeah, that is so that is a treatment. I didn't touch on that. That is a treatment that from the APA, I don't remember the classification. It comes in slightly under the strongly recommended. I know there's a lot of good evidence for EMDR, and that is one of the big three that are highlighted and utilized by the VA. You have cognitive processing therapy, prolonged exposure, and EMDR. There's some interesting research about EMDR and thinking about what are the active ingredients of that treatment specifically, and is it an exposure-based treatment, or is there something to the eye movements? But the bottom line is there's a lot of good evidence for EMDR. It's just not something I have experience in, so I didn't want to focus on that as much.
Okay. Alrighty. What criteria do you look for in a counselor? I mean, this person is looking for a counselor who treats PTSD. What criteria would you look for? You talked about trauma-focused CBT as a gold standard for treating PTSD.
Yeah, I would say really focusing on those empirically supported treatments. So if it is a child or adolescent, someone that engages in trauma-focused cognitive behavioral therapy. If it's an adult, someone that engages in cognitive processing therapy, prolonged exposure, EMDR. Most of those treatments will have some sort of official certification process, and as part of that certification, you are then listed on their website. So I know that cognitive processing therapy has a website, and I believe the others do as well. So, I think a first step would be to go to those websites and see, are there individuals that are trained in these empirically supported treatments nearby, and reaching out to them. If there is no one nearby, I think doing a general search, finding individuals that say they specialized in PTSD, and then really speaking to them and grilling them a little bit. We want to be active consumers, and really recognizing and being able to know, well, is this individual practicing these empirically supported treatments or not, and what's going to give me or my child or my family member the best chance of decreasing their symptoms.
And would you say that the trauma-focused CPT is the gold standard, and why try exposure therapy if other treatments are effective?
Yeah, so I think some of it comes down to personal preference. Especially for the adult, where you have different options. What I typically do, because I am trained in prolonged exposure and cognitive processing therapy, is if someone presents to me with PTSD symptoms, I give them a quick overview of each and see which one they want to engage in. Prolonged exposure focuses more on the exposure component, more on the avoidance. Some people really want to tackle that piece first. Some people, that feels a little bit overwhelming. Cognitive processing therapy focuses much more on the thoughts. What are you telling yourself that is keeping you stuck, and challenging those? And so it doesn't matter to me what type of treatment we do. It's whatever is going to be most comfortable for the client, because ultimately that is going to reduce the risk that they drop out of treatment.
Okay, excellent. I have just one or two more questions here for you to answer.
Mm-hmm.
Talk about people who get into relationships, people marry, they date, etc. I mean, can trauma be you have trauma from a deeply hurtful breakup or a relationship, which results in months of maybe a broken heart, you can't eat, results in some type of PTSD response that causes emotional debilitation? I mean, can you have some symptoms of PTSD as a result of some kind of breakup, emotional breakup and heartbreak?
Yeah, I think you can certainly experience the symptoms. Similar to the other question, I'm just going to kind of give the caveat that, PTSD, as far as the actual diagnosis, is what I outlined as far as, those, what you need is what's called a criterion A event. And so that is that actual or threatened, harm or death. And so that is for the actual diagnosis of PTSD. But again, I really think about treating symptoms, and disorders help guide us and think about what treatments, but realistically, we're focusing on symptoms. And so if these patterns are playing out following the end of a difficult breakup or a difficult relationship, I would approach it a very similar way.
Okay, thank you.
Mm-hmm.
And one more question here. In terms of treatment, in terms of the population that you work with, do you treat children or youth with developmental disabilities, and are there professionals in general trained to work with this particular population?
That is a very good question. I do not have experience specifically with that population. I don't know of anyone off the top of my head that does. I would imagine there must be some. Thinking about trauma-focused cognitive behavioral therapy for children, there is that cognitive component that there could be some limitations there, but there is a strong behavioral component. And so behavioral treatment often does well with individuals with disabilities.
Okay. Well, thank you, Dr. Infantolino. This has really been a very great evening, a lot of great information that was shared, and we thank you for your presentation, and we thank everyone tonight for joining us. Right now, I'm going to turn it back over to you, Kelly, for the final wrap-up. Thank you, everyone.
Great. Thank you all for joining us for PTSD, Unpacking the Myths About Trauma and Exploring Solutions. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Hopefully, it didn't screw up when we screwed up in the beginning. Understanding and tracking implicit biases is our next presentation. And if you don't know what that is, an implicit bias example would be white men can't jump. That's something that we all have heard and believed. It might not necessarily be true. And that is being presented by Dr. Milton Fuentes and is scheduled for March 20th, 2019. This ends tonight's webinar. Thank you, Dr. Infantolino, for your presentation, and thank you everyone for attending. Good night.